وقالت في نهاية المحاضرة differential diagnosis للdiabetes والhypertension. ده هيبقى المين توبيك بتاع الدكتور فاضل والدكتور وسام أستاذ الباثولوجي ورئيس شعبة الباثولوجي في الجامعة العربية للأمراض وزارع الكلى واللي عمل كده وكده خلفياتي. وسام هنتكلم على الباثولوجي of hypertensive kidney disease. اتفضل يا أستاذ.
السلام عليكم. ثانك يو فيري ماتش دكتور عادل. انا بس احب الاول اشكر الاورجنايزرز دكتور ناجي وكل الشباب ومصطفى ومحمد for the invitation. When it's a pleasure to be في جامعه المنصوره for my first time الحقيقه. بس مش هشكركم قوي على التوبيك يعني عشان الناس تشوف ان it's a bit of a boring topic. انا I'll try to do my best and it doesn't be that boring. Okay, whatever way you want to look at the relationship between the kidney and hypertension, whether it is the kidney which starts the story as Sir Richard Wright have said more than 100 years ago, or whether it's hypertension and the kidney. For the sake of the time, I'm going to focus my talk on the pathological changes which occur within essential hypertension, namely hypertensive nephropathy, or what we know as benign nephrosclerosis, and accelerated phase anti-malignant hypertension. Okay, I'll start with the hypertensive nephropathy, what we know as benign nephrosclerosis. Typically, the kidneys in benign nephrosclerosis are reduced in size, and I guess we all know this, that it's the size which is important in a hypertensive patient rather than the ingenuity of the kidneys, and the size ranges between 120 and 250 grams, normal is 300. The two kidneys are usually affected equally, and the capsular surface is most commonly finely granular. The term which is used is leather-like or leathery surface. These granules are due to the formation of the depressed and scarred nephrons as a means from the hypertension together with the hypertrophied renal parenchyma alternating with it, and this is what gives this appearance of granularity. This is the normal surface of a normal kidney, and that's the hypertensive or nephrosclerotic one. Generally, in a hypertensive patient, when you get a biopsy, what you can see, you can find quite a range. We start with that the gloss could be completely normal, or the kidney could simply show age-related changes. One of the first commonest age-related changes are the sclerotic glomeruli. It is common to find some sclerotic glomeruli within kidneys of others, even if they are non-hypertensive. And by time, the sclerotic glomeruli will can disappear and merge between the renal parenchyma in terms we call disappearing glomeruli, and you do not recognize that this is a duct anymore. However, we have two additional types of glomerular changes which we see in benign nephrosclerosis: ischemic glomeruli and what we call solidified glomeruli. Well, the earliest changes is ischemia, and what the earliest thing you get is a duct collapse within the Bowman's space. This is the glomerulus, this is the Bowman's capsule, this pink line, this is the duct, the glomerular duct, and this is what we call the Bowman's space. When you get increased Bowman's space and a normal size, more or less normal size glomerulus, this is what we call ischemic collapse or collapse of the duct. And notice in a collapsed duct, you get thickened capillary basement membranes. However, when you look with the special stains, you see that these capillary basement membranes are actually wrinkles. This is a trichome stain, and it's better seen with a PES stain, which stains the basement membranes, and you see the wrinkling of the basement membranes. This wrinkling of the basement membranes tells you that this thickness is fake. This is a false thickening. This is not a membranous nephropathy or any other disease causing thickness of the glomerular basement membrane. This is just wrinkling of the basement membrane due to ischemia and ischemic collapse of the hypertensive infant. This is followed by more collapse of the tuft, as you can see, and then start accumulation of this pink collagenous material within the Bowman's space, and progressively this is what you get, a completely obsolescent or sclerosed tuft with this collagenous and collagenous material within the Bowman's space. Now we know why the tufts get collapsed, and we know why that they eventually get sclerosed, but we don't know why in hypertension you get accumulation of this collagenous material. And you need special stains to see it. Within the regular H&E, this will be a regular globally sclerosed glomerulus, or what we call an obsolescent glomerulus. However, with the PES stain, even if it's completely gone, you can still see this collagenous material. My fellows, junior fellows and residents, they get very excited about this and say, yeah, we've got a healed crescent, because it does look like a healed crescent. But be careful, no healed crescent in ischemic collapsed glomeruli, and no healed crescent when you get no signs of active crescent to start with within the biopsy. The second type is what we call solidified glomerulus. Now solidified glomerulus, you get the same result. Again, it's a globally sclerosed glomeruli. However, within this context, you get increase in the mesangial matrix. It can be segmental or global, as you can see here, without the accumulation of the collagenous material which we see in the bone space with the ischemic glomeruli, and this is what we call a solidified glomerulus. And so you look at the PES stain and you don't see this pink color we've just been seeing within the ischemic glomeruli. What is the significance of this lesion? The significance of this lesion, usually they have these hyalinotic lesions, as you can see. Even if it's globally sclerosed, you can still see the hyalinosis. You can see the hyalinosis within the arterioles. And if it's segmental sclerosis, as you can see here, you can see that this hyalinosis. When you see these glomeruli within the biopsy of the patient with hypertension, this tends to be what we call decompensated benign nephrosclerosis. Now this term has been introduced by Wall quite some time ago, 1998, and their study of 177 patients. And in around 250 patients, they found these glomeruli together with the ischemic glomeruli. And in comparison with the two groups, they found that these patients with the solidified glomeruli had chronic renal failure within a few years, had higher levels of blood pressure, proteinuria, higher serum creatinine than patients who had solely ischemic lesions. There were other reports of these glomeruli. They were correlated to African Americans and also were associated by what is known as decompensated benign nephrosclerosis, and they represent a secondary form of focal segment. In brief, in summary, when you get these globs within a biopsy, that means that your patient is progressing faster than the regular hypertensive patient you can have. Other changes which you can see in benign nephrosclerosis within the glomeruli will include hypertrophic glomeruli. We all know this, the glomeruli will enlarge in size. We get decreased podocyte number, and this is compared to controls of non-hypertensive patients within the same age groups. Hypertensive patients do get less podocytes in their number, and we all know that decrease in the podocyte number is a factor in glomerulosclerosis, like in diabetes, for example. You can also get lower glomerular number, but more importantly, there's a lower mean glomerular volume. And we've been discussing the number of glomeruli, the reduced nephron numbers, the association of glomerular, or the loss of the number of the glomeruli, and then which ends up in hyperfiltration injury. This is the normal glomerulus, and this is the hyperfiltrating glomerulus. And whatever the reason for the hyperfiltration and hyperfiltrating glomeruli, you will end up by focal glomerulosclerosis, which will then develop into a global type of sclerosis. We had an earlier discussion related to diabetes and to obesity, and actually, even in hypertensive patients, they found that in patients with full metabolic syndrome, where they have obese, hyperphospholipidemic, and so on, they have more tendency to get these focal segmental sclerotic lesions with the hyperfiltration of the glomeruli than just a pure hypertensive patient, to the extent that some postulated that it's the other things, other factors in the metabolic syndrome which helps to accelerate the process of the sclerosis within the kidney rather than the blood pressure itself. So this is for the glomeruli. What about the blood vessel in benign nephrosclerosis? The changes would vary with the size of the vessel involved, and also it differs among individual patients. Generally, it depends. We have different types of arteries within the kidney, and then if you are targeting the arteries and larger arteries, you get your regular, what we call atherosclerosis type of injury, where you get fibrous endothelial thickening with reduction of the vessel lumen and maybe splitting of the internal elastic lamina. In the interlobular arteries, you get fibroblastic endothelial thickening and reduplication of the internal elastic lamina. Arterioles will show hyalinosis, what is known as hyaline arteriolosclerosis. Whether some prefer to use this term, some prefer to use just arteriolar hyalinosis, both are fine. However, arteriolar hyalinosis is important because we found that the risk of arteriolar hyalinosis increases with increase in the diastolic blood pressure, and its severity of the arterial hyalinosis will correlate with the degree of the larger artery endothelial thickening. So the presence of severe arterial hyalinosis within the biopsy can give you an idea about the state of the larger arteries of this specific patient. Now this is a small interlobular artery, and this is a blue trichrome stain or a blue marble stain, and you can see this fibrous tissue which is stained blue. This is the wall of the artery, and the changes can range from this is mild to moderate sclerosis. Sometimes you get elastosis. This is the elastic lamina, this wavy material, this elastic lamina of the artery, and you can see 1, 2, 3, and usually we have only one. And you have this elastic lamina interrupted and ruptured, and this is typically the effect of hypertension. Sometimes the effect is even more severe, and you get splitting of the elastic lamina and accumulation of the fibrous material here, as you can see within this larger artery. Even more severe affection with almost the residual, very much narrowing of the lumen of the artery, with again elastosis. This is what we call elastosis or duplication of the elastic lamina. And this means this term is used to indicate that this patient is hypertensive, that this change is probably due to increased blood pressure. You can use elastic stains to see the duplication of the elastic. All of these layers are the duplicated elastic lamina, marked elastosis in a hypertensive patient. However, we don't use them on routine work. We can readily see the elastic lamina within our regular stains. This is arteriolar hyalinosis. This is the arteriole, and hyalinosis is this pink material within the arteriole. Sometimes on an angiotopsin and ACN stain, you cannot differentiate it between other forms of deposits like amyloid and carotenoid necrosis and so on. And this is how hyalinosis will look like again in a small arteriole. So let me change the mood and make a quick case. This is a male patient who presented with epistaxis and serum creatinine 14 mg/%. On examination, his blood pressure was 230/140. He had metabolic acidosis. The serum albumin was 3.5, LDH 427, sodium 135, potassium 3.6, and potassium 7.8. His urine analysis showed red blood cells 10 to 12, plus 20-25, iron 2 class, protein creat ratio 3.92, and he had granular costs. This is the as you see with the sonar, I don't know which is which, they did not say. However, you had one kidney which was 11.2 and another one which was 9.8/4. Duplex showed no renal artery stenosis. His echo had an ejection fraction of 58% for mild left ventricular hypertrophy. The patient was put on hemodialysis and a biopsy was obtained. Very quickly, what do you think we're going to see within this biopsy? Pregnant, vasculitis. Okay, why? From the clinical history. Okay, any other option? You don't have the clue from the clinical history. His blood pressure is 230/140. He is a young male. Oh, sorry, I forgot to add the age. He's 24 years old. This is the 24-year-old male who came with a serum creat of 14 and blood pressure 230/140.
Yes, one of them is smaller than
Yes, one has smaller than the other. This is true.
One has some renovascular.
He does have a renovascular, but he doesn't have a renal artery stenosis, and his duplex was fine. He did because of the difference. But I think it's less than 2 centimeters in difference. I think one was 9.8 and the other one 11. Anyhow, this is the kidney. And you can see this is almost what we call a green biopsy. You have all of this fibrosis, all of this fibrous tissue, which is green, and you see the glomeruli. I don't know if it's faint enough, but all of these green balls are actually the sclerosed glomeruli. Have a look at these arteries. You see the arteries. This is an artery, and this is blue highlight or myxomatous material here, and this is the endothelial lining and marked endothelial swelling, and within this basophilic haline material or myxomatous material here you have narrowing of the lumen, another artery with the same change. Look at it with a special thing of marked endothelial swelling almost occluding the lumen of the artery, and you have the same entemal changes or entemal degeneration, and look at this arteriole is almost completely occluded by an organized thrombus, and this is a typical case scenario of accelerated hypertension, or what we call malignant hypertension, an acute flare of the malignant hypertension on top of an already suffering kidney from the previous episodes of malignant hypertension. Now, within the current classification of hypertension, the term malignant is no longer used. It's replaced by the term accelerated or accelerated phase hypertension. Malignant hypertension is still used in the literature. However, we do prefer the accelerated phase because it more adequately describes this form of hypertension. Accelerated phase hypertension, or what we know as malignant hypertension, can occur without any history of hypertension, and you all know well better than me that hypertension is asymptomatic. It may be preceded by essential hypertension, and this is an important point. Don't forget that your regular hypertensive benign nephrosclerotic patient can develop at any stage an accelerated phase, and that it may complicate secondary forms of hypertension or complicate on a pre-existing renal disease. The cause of the switch between the benign phenotype and the malignant hypertension is not yet fully understood. However, there was a probable cause for accusation for the renin-angiotensin axis within this switch between the benign and the malignant. What does accelerated phase hypertension or malignant hypertension present like? It would present with what we call a thrombotic microangiopathy. And thrombotic microangiopathy is a pattern of pathology. It's a pattern we see in the pathology, and one of its causes is accelerated hypertension. You can get congested, markedly congested glomeruli, or you see all these red blood cells within the lumina, also within the arteriole, and this pink material is fibrinolysis, and you can get red cell fragmentation, and this represents hemolysis within the kidney. You can get your classic thrombus. Again, this is a trichrome stain, and which stains fibrin bright red, so we know that this is fibrin. And you get all of this blood, all of this orange is the blood, and this is the glomerulus, and this is your classic thrombotic microangiopathy. However, we're not always that lucky, and you don't need to get the thrombi to call it a TMA or thrombotic microangiopathy, whatever its cause. You're lucky when you get the thrombus. But usually this is what you get, specifically in malignant hypertension. This is what we call shrunken glomerulus. You get a lot of mesenterial lysis, this homogeneous mesenterial matrix, and you get a lot of red cell fragmentation, and this is still thrombotic microangiopathy, actually one of the typical presentations of TMA. In hypertension, you get more arterial and arteriolar involvement rather than the glomeruli. So sometimes what you get within the glomeruli are just this mesenterial proliferation and thickening of the basement membranes with the peripheral duplication and MPGN-like pattern. And this is TMA, and by time of chronicity and the repeated attacks, you will get this diffuse thickening with the double contours or the segmental duplication within the papillary basement membranes, and this patient which will present with persistent proteinuria following his attack. Now, as I said, the main regions are arteriolar and arterial, and in accelerated phase or malignant hypertension, you get marked, this is an arteriole, and you get marked endothelial swelling. This white substance is swelling. All of this is edema. Again, endothelial swelling here within this tiny arteriole. Characteristically, you get red cell fragmentation within the wall of the arteriole together with some fibrin thrombi. Things can really get aggressive and you can get all of this fibrin and you can see almost the gun glomerulus, extensive red cell fragmentation, or you can get the fibrin just segmented within the wall like here, stained red, or a full fibrin thrombus completely occluding the lumen of the arteriole. Within the arteries, you can see the changes we've seen within our case, and within this artery, as you can see, this is what we call mucoid entemal changes, or mucoid entemal degeneration, or myxomatous degeneration. All are accepted terms. These terms are consistent with TME and are highly, actually, suggestive of a hypertensive cause rather than any other cause. However, you can see the thrombotic microangiopathy of any other cause, and as you can see, this is the endothelium, this is the adventition, the meter, this is where the enzyme should be, and all of this is the accumulation of this mucoid change. It's actually degeneration of the enzyme, which will later on be replaced by a fibrous tissue, which will lead to marked narrowing of the lumen of the arteries. In repeated attacks, and in patients, especially in patients like scleroderma, for example, you get typically the onion skin appearance in arteries and arterioles, although it's there in arteries, but remember this patient was really magnificent with all of this concentric lamellations due to each one presents an attack of an elevated hypertension. Okay, now this is my second case and I'll need you to be able to this is a female who was 43 years old who presented with sudden increase of serum creatinine from 1.9 to 5.5, then 8 mg/cent. I don't know the duration, but I know it was through a short duration. This patient is a known nephrotic. She had a positive nephrotic syndrome 4 years ago, and she was diagnosed by biopsy as membranous nephropathy. It was done outside my lab. I'm not done here. She's known hypertensive more than 3 years, and she's not diabetic. She has 24 hours proteinuria, 3.9 grams, immunology and biology negative, and though they have done renal biopsy. Now this could include a long list of differential diagnoses, right? Like angiomyopathy, microangiopathy. Okay, out of what? Presenting transformation of membranous nephropathy. Okay. Could be. However, when you get questions with membranous nephropathy, you usually have an underlying disease. It's really very, yes. So you've got another disease. Any other disease? ATN. Renal vein thrombosis, tuberculosis. Okay. All of these are accepted correction diagnosis for the sake of the time to push. This was her biopsy. And I think she was really membranous. She has thick basement membrane. She's already chronic. She has segmental sclerosis. She has thickened bones capsule. You can see some infiltrating edema within the interstitium and tubules. This was almost the only nice, completely patent glomerulus, and you can still see that she is membranous. However, most of the glomeruli which starting to sclerose, and I want you to look at this obsolescent sclerose. Look at the hyperarteriole which you see here. This is the thrombus, and this is a fibrin thrombus. This is onion skin appearance of these arteriole. Again, another glomerulus completely shrunken, and an arteriole with extensive red cell fragmentation and a thrombus. And within her arteries, you already have the chronic changes of the essential hypertension she had, and superimposed on it is the endothelial swelling of the attack of the acute phase of hypertension she got. So, yes, there is accelerated hypertension and pre-existing renal disease, and the question of the primacy of malignant levels of hypertension in the pathogenesis of these microangiopathic lesions is still controversial. However, changes of malignant nephrosclerosis are superimposed in the kidneys with primary glomerular disease, and in these patients, you usually see severe renal parenchymal disease, and these patients have well-established history of an existing, like our patient, an existing renal disease pre-existing before the onset of the malignant levels of hypertension. So some authors consider this as cases of maybe secondary malignant hypertension, and that's why I find the term accelerated phase hypertension actually more suitable to describe all of these variants of the case. In tubular interstitium, whether we are in benign nephrosclerosis or accelerated phase hypertension is more or less the same. These are your closed glomeruli, you get interstitial fibrosis, you get atrophy of the tubules, and you've heard in the diabetic lecture Professor Fatma, you get thickened tubular basement membranes, you can get some hypertrophy tubules as well, so what we call, but usually they are thickened and wrinkled basement membranes, as you've seen earlier, which is immunofluorescence is not helpful in case of hypertension, but we know that arteriole saline changes actually have been demonstrated to show all types of immunoglobulin deposits, but basically IgM and C3. And C3 may also be observed without any accompanying immunoglobulins. The most common reactants we see in cases of malignant hypertension accelerated phase is, of course, fibrinogen. And fibrinogen is not only in the thrombi, but it's also seen within the capillary loops and in the arteries when you don't see the fibrinoid necrosis with your eye. Electron microscopy, again, is not helpful. However, it helps in cases of accelerated phase hypertension if you're not sure of what you are seeing. And this is within the acute phase. This is the basement membrane, and all of this is the endothelial swelling of the glomerular basement membrane. This accumulation of what we call fluffy material, which is exudation from the plasma into the subendothelial space, and this is what causes the thickening of the glomerular basement membrane, and this is what causes the proteinuria, which it's usually subnephrotic, but can reach up to nephrotic levels. That's my last slide. Okay. So my takeaway message that we know that hypertensive nephropathy is still one of the major causes of end-stage renal disease. Accelerated phase hypertension, don't forget that they can develop in patients with benign nephrosclerosis and with pre-existing renal disease. That accelerated phase hypertension presents as thrombotic microangiopathy, and that thrombotic microangiopathy is not hemolytic uremic syndrome. Thank you very much.
Thanks a lot to Wesam for excellent illustrative lecture and lecture. Besides the interesting financial cases, one kindly give us just a few minutes for discussion before leaving. هي سيدة الدكتورة وسام كانت مسافرة على طول على القاهرة. يعني اعتقاد المحاضرة كانت واضحة جدا يا حسام، مش محتاجة هذه القصة. اتفضل دكتور راشد.
Yes. Yes. Hemolytic uremic syndrome is one of the causes of thrombotic microangiopathy. But the two terms does not equal each other.
Yes, I know it is not equal.
Yeah.
But still,
this is just the point. Of course, hemolytic uremic syndrome / PCP would present as thrombotic microangiopathy. However, this is just the point I'm stressing on, that when we have, it's not the other way around. When you have a thrombotic microangiopathy, only one of the causes, and actually the least common cause, is hemolytic uremic syndrome.
The message is, thrombotic microangiopathy is not equally. It's not, I agree with you.
Yes. Thrombotic microangiopathy, the term from, that's what I'm saying.
Even from the clinical point of view, we are not any more use the term hemolytic uremic syndrome.
Exactly.
We are using thrombotic microangiopathy. Is there a way to diagnose the cause of thrombotic microangiopathy based on only the histopathology?
No. They all look the same. We can only have some things which suggest, but that's all.
Malignant hypertension may be a cause for thrombotic microangiopathy. And the hemolytic uremic syndrome is an entity that has different clinical, pathological, and pathogenic mechanisms. But the presentation is a thrombotic microangiosis. So thrombotic microangiosis is just a presentation
It's a pathology pattern. Yes, it's a pattern in the pathology.
My question is, when you look at kidney biopsy and you find hypertensive change in the kidney, would you be able to know most of the time that this is a hypertension causing kidney disease or a primary kidney disease complicated by hypertension? Would you know that?
That's very difficult. It depends on the stage of the disease. We evaluate between the changes we see in the glomeruli, and if the tubular interstitial changes are out of proportion, then you got a primary tubular interstitial disease, or if the vascular changes are more out of proportion. But sometimes it's impossible to decide which is the primary cause of injury. What started, what's first is very difficult. Thank you very much.